So I will try to make it a little bit simpler, and I have very few slides, probably about 10 slides, and we can see if I can make it as simple as possible. So I'm going to be talking about how we monitor the disease and how we make decisions. And more importantly, as you might have heard in the morning, there are a lot of therapies, just Dr. Ataya mentioned, there are a lot of therapies evolving. Dr. Gertz is mentioned, we're going to talk about CAR-T. So how we monitor those disease in the clinic, and how we make the sequencing of this therapy so that you get the effective therapies at right time. And so this is the natural history of myeloma that will apply to majority of the patients. You might have seen this graph. It is very, very common figure that is being shared everywhere. So the graph it tells you is that the myeloma, as you know, it starts from a benign condition. It's like a colon cancer. So when you talk about the colon cancer, most of the time it starts as a polyp or called adenoma. So that is a benign, that is not a cancer. Similar to that, the myeloma starts with a condition called MGUS. That means one of the plasma cell kind of decides to become abnormal for reasons unknown. And then that is very common condition. So that is present in about, people over 50 years of age, about 3% to 5%, and can grow up to 7% over people above 70. So that is a common condition, but we know the myeloma is not that common. It is the second most common blood cancer, but it is not very common cancer overall. So this MGUS will go on to develop myeloma, and the patient presents to us with either any kind of target organ damage like kidney damage or bone damage, or sometimes they can be just diagnosed incidentally. You go to see a primary care doctor, and then you see your protein elevated, and then they do the workup and you have a myeloma. Now, you do a treatment initially, the disease responds very nicely, but unfortunately, this is an incurable disease. As of now, we have not been able to cure the disease. We can control the disease, but haven't been able to cure. So invariably, everybody relapse. And you can see the graph going up, that is the disease burden coming back up again. And then you give a treatment, fortunately, where we have a lot of good treatments available, it goes down and comes back again. Ultimately, it becomes such a tough disease to treat that it relapses and refractory to all the agents that we have. Now, what is important to know is that with each relapse, you can see the duration of the remission becomes shorter and shorter. Ultimately, becomes very difficult disease to treat. So that is the natural history of myeloma applies to most of our patients. Of course, there are some patients who are very fortunate that their disease remain in remission for a long time. And there are some patients, who remain in smoldering phase. They never developed myeloma. But in majority of the patients, once the disease starts evolving, that is the pattern. Go to next slide, please. So how we diagnose the patient and how we monitor the patient. These are the number of tests that is listed out there. Basically, you need few important tests to diagnose the disease and monitor that. So in myeloma, we're very lucky, I would say, that we can just do the blood work. And from the blood work, you can monitor the disease. For example, in other cases, in other cancers, you might need to do a biopsy, you might need to do imaging. Imaging is an important part, but just by the blood work, you can monitor the disease. So those antibodies that Dr. Ataya was mentioning is one of the specific to the plasma cells, to the cancer cells. So you can monitor that in the blood. And so initial diagnosis, you do all this tests from blood counts, from bone marrow biopsy, from the scan, because myeloma likes to involve the bones and can involve different parts of the bones. So we need to make sure that is detected at the time of diagnosis. Then after that, you do a blood test to monitor the disease. And the blood test will tell you whether that protein or the extra antibody is not there or it is coming back up. And we have other further tests like a light chains. The light chains is the one way to monitor the disease as well. Some cases, the myeloma only makes the light chains, so you can probably just monitor those by the light chains. In very few cases, for example, about less than 5% of the cases, the myeloma cells may not make anything. They are called non-secretory myeloma. So in that case, you have to rely on very sensitive imaging like PET scan, MRI to monitor the disease. And so here is the picture. It shows you the PET scan image. The one here down shows the lesion there. And this on the right side tells you the different sensitivity of detecting those malignant plasma cells. So first is by the blood work, and this is as shown here, the sensitivity, as you go down further, you are getting more sensitive tests. For example, just doing a blood work, you may not see the cancer in the blood work, but that doesn't mean the cancer is not there. You have to go down to the bone marrow and detect the disease at the time. And there also, there's a different level of test For example, doing a flow cytometry, the pathologist will do that. Then the new test is called MRD test. You might have heard about that, minimal residual disease, detecting the disease at even lower level by gene sequencing called next generation sequencing. And of course, the imaging is a very important part of for the disease evaluation. You do that at the time of diagnosis to see what else the damage has happened. And the next is further down, you also do the imaging depending on the symptoms and also to see if those lesions have gotten better, especially if those bright lesions in the PET scan, if they have gotten better or no. So this is an important test as well. And there we can see what the sensitivity of the test is. Now, conceptually, if you look at it, the disease is like iceberg. What you are seeing in the surface may not be true of what is down there. Okay, so what you're seeing in the surface is what you see in the blood. So when somebody achieves the complete response, that means you may not be able to see the disease in the blood, or maybe very little amount of disease in the bone marrow. But there are a lot of disease could be hiding below the surface, and that's why we are fortunate to have a lot of very sensitive tests right now, including the MRD testing to detect those diseases. So the way I explain to the patients, my patients, is that you're going to a ocean and you're trying to look for a particular color of the fish, which is a myeloma cells, and you fish out about up to million cells, and you don't see the fish, that particular color fish, like red fish or something like that, and that means you are MRD negative, at least with that current level of sensitivity. So you go to up to 1 million cells and you try to fish for those specific cells, and you don't see the plasma cells. So there are two ways to do that. One, you can do by flow cytometry. So the pathologist can do at your a specific institution, looking at the markers of those cancer cells. And other is doing by the gene sequencing, which is looking at a specific genetic sequencing of that antibody that your cancer cells are making. And that is very particular to that. So you can track that sequence over time. So at the time of diagnosis, we get that sequence, and then we keep the track of that over time and see how much that has gone down, or if that is eliminated after the treatment. So they're very, very sensitive tests and very important tests, and they are showing the importance of clinical outcomes, slowly, and they are being used in the clinical trials and hopefully in the clinical practice in the future. So next, please. So why MRD is important? I think there was discussion in the question about MRD. MRD is kind of a hot topic right now. Everybody talks about it, but nobody knows what to do about it, right? So that's what it is right now. But what we have shown, the well-settled debate is that MRD is very prognostic. So this is the first paper, or one of the main big paper that looked at all the myeloma patients were treated with the different types of treatment, transplant, no transplant, and looking at the MRD at different ways, not one particular way. They looked at the MRD by flow, they looked at the MRD by gene sequencing. What that showed is that if you achieve MRD negativity, okay, that means if you are not able to see the disease at a very low level of your test sensitivity, and if you compare that patients to other group of patients who are MRD positive, you are going to do better in terms of your disease being in remission for longer time. So that means your progression-free survival will be longer. And number two, you also live longer. So they have survival advantage as well. So it's very prognostic. This marker is very prognostic. Now, what we don't know is what we do if we have MRD positive, or what we do if we have MRD negative. For example, a lot of my patients ask the question, do I stop maintenance? And do I really need to go to the transplant? So those kind of questions we don't know yet. And there are a lot of trials trying to answer that question, try to investigate whether MRD can be actionable. Can we do something on MRD? And hopefully in the next 4 or 5 years down the road, we will say that, okay, you are MRD negative for this 2 years or 3 years, maybe you don't need this or something like that, which is kind of something that we want to look for as well. Next. So the most complicated part of myeloma, I would say, is once the disease relapse. Okay, as you already saw, the disease becomes refractory to different lines of treatment. They don't respond to one particular drug and all those stuff. So once it relapse, then becomes challenging. But more challenging is that there are a lot of treatment out there, and we don't know what is the right or what is the best treatment. Because if you look at it, the way the relapse is defined is that early relapse, if you have just finished 1 to 3 lines of treatment, and the late relapse, and they are completely different disease, early relapse versus late relapses. And in early relapse itself, there are so many drugs that are approved by the FDA, which is a good thing for us, but at the same time, that brings up another level of complexity, what to choose and which is the best drug, because they are not compared head to head. Means For example, one of the drug that is approved by FDA for the first relapses, after first relapse is daratumumab, Revlimid, and dexamethasone. At the same time, carfilzomib and dexamethasone and the drug that is approved, but we don't know which one is better because they are not compared against each other. So that brings up the whole level of complexity. So how to choose the right regimen so that the patient get the best benefit with that is basically an art, basically an individualized approach, a kind of more or less precision approach. And what we need to think about at that setting is three factors mainly: patient-related factors. So how old is the patient? How fit is the patient? And then what are the comorbidities the patient has? Did the patient have a poor heart function? Does the patient have poor renal function? So those are the things we need to take into account. The other thing we need to take into account is disease. The disease-related factors means all the relapse are not the same. Okay, some people relapse with the very aggressive relapse. They come with the kidney failure, bone fracture right at a time. Whether we have seen a lot of patients, you might have experienced that your numbers go away slowly, and you meet the criteria for the relapse, but you are doing fine, have good quality of life, may not have any symptoms. So that is called biochemical relapse or indolent relapse. So they are completely different. And you probably have to choose what kind of regimen is going to be the best in that setting. And lastly, the treatment-related factors, very, very important. So when you say treatment-related factors, they are like you have received some treatment before when you started the treatment, and then you start at the time of diagnosis, and that treatment gave you some residual toxicities like bad peripheral neuropathy or some effect on the heart, then that is treatment-related factors. And when you choose the next regimen, okay, then you have to decide what regimen to choose or what combination to choose. So these three things are very, very important. On top of that, the patient preference, the patient ability to support, the patient ability to come to the center. There are some just oral regimen only. The patient probably want to have that oral regimen, but there are some IV regimen requiring weekly visits to the center. So those are the things that take into account when you decide what to choose. So just to give you a brief kind of a synopsis of what we do at Medical College of Wisconsin. First, when you have early relapse, you confirm there is a relapse. There is a test that we do by blood test and maybe even by bone marrow if needed. And then you see whether the patient is on maintenance or no. As you know, most commonly used maintenance is Revlimid maintenance. So if somebody is relapsing on maintenance, then you definitely don't want to use the regimen containing Revlimid maintenance because there are a lot of things that is approved on that. So you try to choose some of the regimens I have listed there. And more importantly, you also decide whether it is a fast or slow relapse. If it is a fast relapse, you want to give something that acts very quickly and that is a little bit more powerful. And then if it is off maintenance, which is the one that we don't see that much in the US, then you choose one of those regimens. So this is just an example of what we do, and there might be some variation across the institutions, but more or less, this is the principles of all those three factors that we take into account. And the next slide, please. And once the patient becomes late relapse, then it becomes completely different disease, okay, than early relapse. So in that case, our preference is to go to clinical trial, and that's what I kind of always tell my patients. Once you have finished the 3 lines, especially 3 lines means 3 class of drugs, the proteasome inhibitor, that is bortezomib, kyprolis like drug, the lenalidomide, that class of drugs, and CD38 antibody, then the disease becomes very tough to control, and you need newer therapies with novel mechanism of action. And there we recommend doing the clinical trial. Fortunately, in the last 2 to 3 years, we have got very good approval of very exciting compounds. And Dr. Ataya mentioned there might be one coming up in the market with the bispecific antibodies. They look fascinating. They look very good in terms of the activity. CAR T cell, we have approved. We have got the approval of 2 CAR T products, so that is all good. But at the same time, there are a lot of other novel kind of a targeted approaches in the clinical trial, both for immunotherapy and non-immunotherapy options. So we'll try to put them in the clinical trial. So I think then I probably have, okay. So then the new class, which is an unmet class of kind of a thing that will come is after you relapse with a particular target. And in this case, the BCMA target. The BCMA target is the one that has been shown to be very active in patients who are relapsing after those 3 classes of drugs. And we have a CAR T cell, 2 CAR T cell for that. We have a ADC, the antibody drug conjugate, and hopefully we have a bispecific antibodies. But what we have also seen is that the CAR T is not curative in myeloma, and people relapse after that. So after BCMA, or what we call as a 4 class of drugs relapse, that becomes even more challenging. And this will be more challenging going down in the future. And these are some of the strategies that we do Fortunately, we have a lot of non-BCMA targets that is in the market, that is in the clinical trial. For example, targeting a target called GPRC5D, which is a bispecific antibody. There is another target called FcRH5. So we had a lot of trials showing the benefit even in patients after BCMA relapses. There are some data emerging using another BCMA target agent after relapsing with the first one. So these kind of things that will come in the future, how to sequence these agents after you relapse after those multiple different agents. And then lastly, I think this is very, very important. I always tell my patients and the community doctor is when to refer to a specialist. The referral early is the key because myeloma is becoming so complex. It's a small disease, but very complex. And especially with a lot of new drugs coming in the horizon, it is becoming even more complex. So I always tell my patients and the referring doctors, please refer early because you'll hear later on, drugs like the CAR T cell therapy, all those like potential life-saving drugs are, approved at the late lines, and where very few patients might get benefit because they don't get to see that opportunity. So it's always best to refer early at the time of diagnosis or at the first relapse. And of course, when you are going for transplant, they get referred early to a specialist, but it's important to continue the care with the specialist at some frequent intervals. But if you don't refer early, at least at the time of the first relapse, because there is a benefit of doing transplant at first relapse as well. And at the same time, if you relapse after major class of drugs like the PI, IMiDs, and the CD38 antibody that I just mentioned. And it's always important to have the continuous communication with the community doctor and then co-management. So for example, sometimes my referring doctor calls me, and I always encourage them to call if anything changes in patient condition, if anything happens in the myeloma, so that we can just co-manage together. I think that's all I have. Thank you so much.